Hello. Day two of summer of 2024, and we are on day two of our internship. Today is a very interesting conversation. You'll have two very bright, brilliant minds speaking to you. I'm planning to attend the whole of it. I'll be sitting somewhere here and learning from the one and only Dr. Shambhavi Jaiman and Dr. Trideep Chaudhary. Um, Brilliant minds, brilliant psychiatrists. Academically, we look up to them to give us solutions. I, in any case, don't know half the things by now. That's probably viral, right? And so I also keep going to these colleagues of mine to ask them what is what are the new evidences, what is the new school of thought, and with all of these diagnoses that change. When I was a student, we had DSM 4, then 4, then 4TR came, 5, and now 5TR. I think when I was a student, it was ICD 9. I don't remember, was it 9 or probably 9. And then we had 10, 11 now. So what we thought was today we have a conversation around psychiatry diagnosis, a diagnosis which is where we'll also talk about both the ICD and the DSM. We have our own experts here, our DSM expert, Dr. Shambhavi Jaiman, our ICD expert, Dr. Trideep Chaudhary, and they're going to go through this entire 3 hour session. If after 45 50 minutes or so, if you guys need a 2 3 minute break, feel free, just type into them and request them for a break, and we'll take a short break whenever you want. The attendance link has just been put by anuna.bordoloi at fortishealthcare.com. anuna.bordoloi at fortishealthcare.com. If there are any questions from yesterday, you can ask me right now, but my questions will be on ethics. If there are other questions which are on the policy, then I'll have to ask one of our colleagues to take those answers. I not my area of expertise, but should you focus more on DSM and ICD? Frankly, it doesn't matter. I studied DSM, so I understand DSM a bit better. But I think both have their. I think in these times we should try and read, have an understanding of both, and more importantly, you would also realize, and I'm sure my colleagues will share with you, that you are looking at a merger happening, which means both of them are almost going to soon enough have very similar diagnosis. There is very little difference left, to be honest. Can you do a PhD? That's a question I'm going to let someone else answer, or you can send that question to anuna.bordoloi at fortishealthcare.com. So if you want to ask questions on what I talked about yesterday, which is ethics, you can. If you want to ask questions on some of these qualifications and degrees, I'll just ask a colleague to join in. And DSM ICD, just let the experts come. Feel free to ask them your questions. Okay, if you have no questions, can I move forward? Okay, so let's meet Dr. Trideep Chaudhary. Is he there? Yeah. Somebody needs to switch on his camera. No, but how do I add? Which one is he? Yeah, but his camera is not on. Oh. So that the black screen is Dr. Trideep Chaudhary, but I'm sure he's going to join us soon. Somebody has gone there to switch on his camera. I'll wait for his camera to be switched on. Meanwhile, yes, that's true. DSM is largely used in US and ICD 11 almost everywhere else. That's actually true. Okay. I think they're helping him join in. Meanwhile, let me also start adding in the presentation for you. You will be getting the assignment. See, I got a prompt here. I forgot the word assignment. All I need is a prompt and a teleprompter, and probably it'll be all fine. You want yesterday's assignment link? Anuna.bordoloi at fortishealthcare.com. Can you please send? Yes. She's done some this, but I don't understand what does it mean. You know what? Let's just ask her. What were you saying?
Oh,
Yes.
hi, sir. Hello, everyone. So the link for assignment for yesterday is there on yesterday's YouTube link on the description box. It is pinned, so you can just go there, fill that assignment. The attendance link will be there on the comment as well as the description box. So any day's assignment that you need, you can go to the comment section. There we will be pinning the assignment link, and the attendance link, it is available on the description box. Right? That's all.
Whatever Anuna says is right, okay? And that's anuna.bordoloi at fortishealthcare.com. When are you going to get your internship certificates for the previous one? I will get back to you on that. It's just that anuna.bordoloi at fortishealthcare.com is probably not compiled the words, the Excel well, so that's why. Yes, you will need to complete all your assignments. I don't like to call it homework, but feel free to call it what you want. And you will need to give us 80% attendance. Can you share the attendance link again? Of course, why not? Anuna.bordoli at fortishealthcare.com. Can you please give us the attendance? While we are trying to get Dr. Sudeep Chaudhary, um, yes, and I can now see the very famous Dr. Trideep Chaudhary is now here. So that's Dr. Trideep Chaudhary. He's a psychiatrist, and I'm going to add on the other psychiatrist who's going to come in. That's Dr. Shambhavi Jaiman. Now, what we'll do is I go and I leave you in the very bright, brilliant hands of Trideep Chaudhary and Shambhavi Jaiman.
Hello, everyone. A very good afternoon to all of you, and a very big thank you to Dr. Sameer Parekh, who has graciously introduced me and Dr. Trideep, both of us. Like Sir mentioned, we are both psychiatrists, and we are going to be talking about the topic for today, that is orientation to diagnosis, ICD-11 and DSM-5-TR. So how we are going to go about it is we have divided it into sections. So initially we would be introducing exactly what is classification. Both the classifications we would be comparing, and then we would be taking on the ICD-11 and then DSM-5 and the changes which have recently come up in DSM-5 to DSM-5-TR. So that's how we are going to go ahead with it. So what I'm going to do is that I'm going to be starting with Dr. Trideep. If there are any questions, please feel free to mention them in the comment section, and we'll take up the questions. And like Sir mentioned, that if you get tired in between, you can always ask for a break and we'll give you a small break. It's going to be a long session today, so let's start, I think. So when we're talking about orientation to diagnosis, a very important thing which comes to all our minds is that what is the criteria? How do we diagnose? Yes, we see a person, we get all the history from them, we collect all the information from them, and then what do we do? So that is where the classification or the diagnostic criteria come into the picture. The main diagnostic criteria which have been used for a very long period have been ICD and DSM-5. Right now, the current ICD is ICD-11, which was introduced in 2019. It is still in the process of getting adopted by the practitioners, whereas the current DSM is DSM-5-TR, which was also introduced recently and is already getting adopted in the classifications. So when we talk about introduction to classification, what do we mean with classification? Classification is basically the process of putting things into groups based on their likes and what is not like in them. So if we see that there are certain similarities, there are certain things which are similar in certain disorders, they would be clubbed into one classification. That is what the basic definition of classification is. Classifications in psychiatry, when we talk about that, it is also said or called as psychiatric nosology or psychiatric taxonomy. It is a process by which complex phenomena are reduced by rearranging into categories based on shared characteristics, similar to the normal classification, right? So if there are a set of disorders which share similar symptoms, they would be put in one category, and so on and so forth. So this is what the classification or classification in psychiatry means. Now, why do we need classification is something which we need to think about. Um, I might be sitting here, I might be talking to a person, I might take all the history. The same person will go to another part of the country, to another continent, and they might consider taking help from somebody else over there. There would be difference in opinion, there would be differences. Psychiatry, psychology is a very subjective field, so it is important that there is some amount of standardization which is brought into the classification, so that this discrepancy or the difficulty in putting the classification all over does not happen. So, one, it helps us put disorders in diagnostic classes. It allows mental health practitioners and researchers to communicate effectively. Like I said, that if I'm here, I might have a certain perspective about an illness. If somebody else is there and if there's no criteria, they might not be able to have a certain standardized form of discussion. So, communication is enhanced by having a certain classification in picture. To arrive to a diagnosis that has important predictive power, when we are talking about diagnosis, a lot of times it gives us an idea as to what is the prognosis, or what is the, how do we see the near future, or the treatment going, how what are the different kinds of things which can come up with a certain diagnosis. So to arrive at a diagnosis that has predictive power is helpful with regards to the treatment. To distinguish between one diagnosis from another, obviously, if this is a set criteria, there are times when there can be overlapping symptoms. So just relying on symptoms and not on the diagnosis is not always the best idea, because there can be overlap in symptoms between the disorders. If you have a certain disorder classified, most of the symptoms fit in this criteria, then we would go ahead with this, rather than if there is something else which has certain overlapping symptoms but not all the criteria fit. Structure for teaching phenomenology and differential diagnosis, understanding this particular diagnosis is the differential diagnosis for this particular diagnosis, the differential diagnosis for this, and picking up what is the most appropriate diagnosis. It is helpful with that as well. Psychoeducation of the families and the patients. It also helps in making them understand as to what is the background from where this is coming from. It helps us make them understand in terms of symptomology what are the things which we need to be careful about. So it helps in psychoeducation as well. And healthcare epidemiologists to determine the incidence and prevalence of disorders. This basically is, with regards to the DSM, because DSM gives a lot of background on the prevalence in this incidence of the disorders. So that is what I think we need to focus on. So it will help there as well. So basically, it is with regards to DSM. Dr. Tradeep, would you like to add anything
Yeah,
with regards to advantages?
yeah. Thank you, Dr. Samapi. I think it's a very good explanation to begin with. I know, if we look at ICD and DSM, I know the first question or the first, the thought that arises in our mind is why two classifications for a, for a single branch of medicine. So there where lies, the beauty of psychiatry. Psychiatry has got a biopsychosocial, model when we go for the treatment. So as ICD, it was first initiated by WHO, and DSM was first initiated by American Psychiatric Association. So both had different cultures and both had different view of looking into diseases, and that's how two classifications of diseases came into being, to classify the same branch of medicine. But as time went, uh, people or those who are responsible for bringing out this classification, they realize that there has to be some kind of a bonhomie, or there has to be some kind of similarity between those two classifications. And if we see the different different editions of ICD and DSM, there is more coming together of the later part of editions of ICD and DSM. And the current DSM-5 is and DSM ICD-11. Actually, there has been an effort from both the sides so that diseases can be classified more uniformly. And now another aspect which I would like to bring to notice is, for classification, the approach has been more dimensional than categorical. For example, ICD, when we classify any diseases, there would be one would one would diagnose a certain kind of say person with a single diagnosis. But what we have come to know from our experience is that there might be dual diagnosis, or say some features might be present to a certain extent, whereas some other features may be present to a certain extent. Say a person with ADHD might also have conduct disorder, or a person with mood disorders might have OCD symptoms. So these are two different diseases, but to do proper justice to both the disease diagnosis, one has to maintain a dimensional approach. But when we're maintaining a dimensional approach, there are certain disadvantages. For example, research work becomes difficult. So what the current ICD and DSM have done is they have brought in a dimensional approach to a already present categorical approach, and you would see that lot more of specifiers have been added. For example, to find out the severity, say a depressive disorder would be specified as mild, moderate, or severe, or say a depressive disorder would be specified according to the course of the disease. For example, whether it is in remission, in partial remission, or in acute phase. So that's how has been the journey of ICD and DSM. So Dr. Samruddhi, if you can carry forward.
Yes, so absolutely right. So when we are talking about ICD and DSM, like Dr. Siddhi mentioned, that there is a scope that there would be a merging or a merger of sorts to happen with both the classification. But right now, where we are standing, there are certain differences between ICD and DSM when it comes to the classification aspect. One, ICD has been made by the World Health Organization, that is WHO. The DSM, a lot of people would know that it has been made by the APA, that is American Psychological Association. The use of ICD is mainly in Europe and other parts of the world as well, but DSM is something which is more commonly used in the US. ICD is available in all the languages. DSM has been introduced in English and stays in English. ICD does not really take into account a lot of social factors, but whereas in DSM, social factors, a lot of other information about environmental factors, etc., has been provided. So if you've seen the DSM textbook, it's like a small mini psychiatry textbook, which gives a lot more information than what ICD gives. ICD sticks to the criteria. ICD does not just stick to mental health. So ICD is International Classification of Diseases. A part of it gives us the classification for mental health. In ICD-10, that was the chapter 5, the F category of the disorders. In the current ICD-11, things have changed. Whereas DSM is only for mental health disorders. ICT focuses more on helping the psychologist and the psychiatrist in terms of understanding the criteria and diagnosing the illness or the disorder, whereas DSM is created with the idea of being useful for different health systems around the world. Like I mentioned, that it takes into account a lot of other factors, social factors, environmental factors. It provides insights into the incidence and the prevalence of a lot of disorders. So it gives us more information. So these are the main differences between the ICD and DSM when it comes to the classification and the origin of it. So this is how the current ICD-11 looks. It is an orange colored book, whereas the DSM-5 TR is a teal colored book. Um, the ICD-11 is still in the process of getting adapted and adopted into practice. DSM-5 has taken a little more advancement with regards to that. Uh, Introduction to ICD would be taken by Dr. Trideep, so I'll leave Dr. Trideep to it.
Yeah, thank you, Dr. Shambhavi. So when we talk about ICD, as Dr. Shambhavi has already mentioned, it is not only about the mental health issues, but also about the overall, all the diseases are being classified by ICD. So when we come to ICD, that has been the journey of ICD, and till now there has been 11 editions. Uh, ICD-1 was in 1900. If I'm not wrong, DSM was started much later, around say 1950s, I suppose. And uh, the DSM, the latest edition is DSM-5, the revised edition. So when we talk about ICD, the latest the ICD-10, which was the previous one, there the diagnoses were they were classified according to different axes. So axis 1 consists of the disorder, and axis 2 consists of what kind of impairments or what kind of implications a person would have in his social, emotional, and in his work atmosphere. And the axis 3 consists of the environmental factors, the circumstances under which the person was is being diagnosed with the disease. So the current ICD has got the ICD-10 has got 3 axes around which a diagnosis was made. No such mm, axes are maintained in the current DSM. So if we see the ICD-10, so there are 5 chapters, and they have been categorized as F category. So say if and moreover, both alphabetical and numerical format will use, so it is alphanumerical. So for example, schizophrenia were diagnosed as F20. So and it is quite a descriptive classification, as more research work has come in for the ICD. And one thing I would like to say that the major difference between DSM and ICD was that ICD was basically for each and every general physician, and DSM was more for the the psychiatrist, the psychologist. So what they have done is that ICD now they have while diagnosing, while making the classification, what they have done is they have taken into account all the experiences that have been shared by the general physicians. So WHO caters to many countries. So many countries the physicians give a lot of information, and based on that they have made the classifications. Whereas DSM they have given more emphasis to the empirical work, to the research work. So when we go through DSM and ICD, we'll find that most of the diagnoses which are present in ICD may not be there in DSM, because although these diagnoses were made based on what the information was shared by the anecdotal reports, whereas DSM, they um, they believed in more, more research work. That's how, they have diagnosed. For example, if we look at uh, postpartum, say, depressive disorder, if you see ICD, it has been made a single diagnosis. For example, postpartum depressive disorder. But whereas in DSM, they have looked it from the psychiatrist or psychologist point of view, and what they have, uh, what how they have diagnosed is the same disorder. They have put it into, say, in the pregnancy group with the specifier of, say, peripartum onset or postpartum onset. So what they have done, they have looked through the lenses of a psychiatrist or a psychologist. Uh, if we see the ICD-10 and ICD-11, ICD-11, they have increased the number of groupings of disorders. The new additions are intermittent explosive disorders, prolonged grief disorder, complex PTSD. If we look at complex PTSD, the same thing has been described in DSM, but whereas in your ICD, they have divided PTSD into simple PTSD and complex PTSD. So in PTSD, post-traumatic stress disorder, there are three sets of, you need to have symptoms. For example, avoidance symptoms. You need to have intrusive symptoms. What they have done is in PTSD, if a person is having some mood symptoms, say he or she is having some depressive symptoms, or say anxious symptoms, so what they have done, they have categorized them into a complex PTSD, complex post-traumatic stress disorder. Whereas when a person doesn't have these mood symptoms, they are classified as simple post-traumatic stress disorder. Similarly, they have added excoriation disorder, olfactory reference disorder, body dysmorphic disorder. Bipolar 2 disorder has been added here, whereas in ICD-10 it was categorized under bipolar 1 and bipolar 2 were kept together. Catatonia, avoidant restrictive food intake disorder, binge eating disorder, hoarding disorder, compulsive sexual behavior disorder, which is put in the impulse control category of disorders. Gaming disorder, body integrity dysphoria, and premenstrual dysphoric disorders were added in ICD 11. So again, ICD 11 has added different specifiers to make the diagnosis more descriptive. For example, say if the um, mm, if say the disorder was in remission, they mentioned it as uh, certain disorder with full remission or partial remission, or uh, you know similarly, severity specifiers were used, symptom specifiers were used. Symptom specifiers, for example, say if certain symptoms were more prominent, they would add as specifiers. So this was absent in ICD 10. Uh, these are just the diagnoses which were made according to ICD 10. This is how the ICD 11 has been, they have been categorized. So we're going through this fast because it's very difficult. It's not possible to go through each and every category. So later on we'll come to this in details. So in personality disorders, I would like to mention that in ICD-10 they have mentioned various personalities. Similarly, that has been done in DSM. But in ICD-11, they haven't mentioned the different personalities. What they have done is they have said that if a person has got functional impairment or social impairment, then it's a personality disorder. And if say a person would have some borderline traits, that would be add as a specifier. But not as different personality disorders. One more thing they have done is, the childhood disorders are not mentioned here in a different category as has been done in DSM-5 TR. And what they have done, if any childhood disorder was there, they would mention which specifier in a particular group of diseases. For example, a depressive disorder person who is below, say, about 10 years, it will be mentioned in the depressive disorder category, and it was mentioned which specifier it is whether it is what is the age and all. So I'd like to I'd request Dr. Samavir to carry forward from here.
Right. Thank you, sir. So, like Dr. Sudeep mentioned, that from ICD 10 to ICD 11, there have been certain changes in terms of the diagnosis, which have been added, certain severity specifiers, certain symptom specifiers, etc. A very important thing to note is also the change from the coding. The coding has changed from how it used to be and how it is currently. So ICD 11 has a different coding, if you would have noticed, and the ICD 10 had the F coding. So somebody in the comment section when I was going through asked that why is the alphabet F chosen? There's no particular reason as to why F has been. It's not being chosen. Like we mentioned, that ICD classification is the classification of diseases over all the aspects, not just mental health. So it includes all the physical health disorders, it includes all the orthopedic related disorders, it includes everything. So when we are talking about the mental health, it falls in the F category. There's no particular reason to why it was chosen. Dr. Sadeep, if you don't mind, we can probably take some questions so that we can
Yeah, sure,
what
sure.
we want probably. Uh, So that was one of the questions which I could see. I glanced through and I could see. The other was that is it somebody wanted to know if it is necessary to get the textbooks of ICD and DSM. It is always good to have reference to these books. Need not be in physical form. You can get the soft copy of it for your reference. It's definitely beneficial to understand what is ICD, what is DSM. DSM also gives you a lot of background about the illnesses, unlike ICD. So I think it would be good if you have access to it.
So there is another question where they have asked whether do we need to memorize the codes. Memory. You don't have to memorize all the codes, but as you practice, and you go through the textbooks again and again, certain diseases, you get used to it. So you don't have to. We don't. What we do in practice, we don't memorize every code, but then the major categories, when we use it on a regular basis, we do remember it. We do, memorize it. The second thing is that someone has asked about why do we read DSM when we are using ICDS practitioners. So, we should bring the same kind of approach, like the makers of ICD and DSM have used. It's not going to conflict, and both ICD and DSM have their own strengths, and we should use them. I think we can use any of the classifications, any of the standard classifications. I think both are fine. What's more preferable in India, ICD or DSM? We use both the systems, ICD and DSM.
Right. So we can probably start with the DSM and then we can take some more questions. I think there's another question about the concept of axis in ICD. Dr. Tadip, if you'd like to explain that, the multi-axial. diagnosis in ICD.
Yeah. What was the question?
The concept of axis, the multi-axial
Vaccine. Okay,
diagnosis.
fine. So what we do, when we diagnose a disease, it's not only about the biological component of a disease, it's also about the psychosocial component of a disease and how the disease or the disorder has affected the person uh, uh, um, in his social in the social life, in the functional aspect and all. So in the axis one, we describe the disorder. For example, someone is suffering from depressive disorder, we describe it on in axis one as depressive disorder. And say if the person is not being able to go to work, then impairment in work will be described in axis 2. Along with that, say the depressive disorder has arisen because of some situation or circumstances, say loss of a loved one, or say some in interpersonal events that would be mentioned in axis 3. So by why they have given the concept of 3 axis, it is done for the for the clinician's benefit, so that we can judge, we can find out the correct plan of action, the correct plan of management for the disorder. Say if there is a stressor, we can work on the stressor. We can if there are some issues relating to interpersonal relationships, then we can work on that, and can that can be a good thing to do to get rid of the symptoms.
Right. So let's move forward with the DSM. The evolution of DSM started in 1952 when the first DSM was introduced. Now, there have been multiple DSM versions which have come after that, DSM 2, 3, 4, 5, and the current DSM which we are using, which was introduced in the year 2022. And we're still sort of adapting to that, is DSM 5 TR. Somebody had asked in the comments as to what does TR stand for. So TR stands for text revision. So we had DSM 5 before. DSM 5 TR is one step ahead of that, where when there are certain cumulative changes which have been identified, then a new revised version of the DSM comes. And if it is mainly with regards to the text and the language. You will see when I talk about the DSM changes from 5 to 5 TR, that there were a lot of text changes which happened. It's just the language of how the criteria was being phrased and things like that. So that is something which is DSM 5 TR. So it was introduced in 2022 and currently we are following it. So when it comes to DSM, unlike ICD, DSM follows a chronological order of, uh, you know, describing the disorders. So we start with neurodevelopmental disorders and childhood related disorders. Then it goes on to disorders which can happen in adult as well as children, and geriatric age group as well, common section. And then it goes on to some organicity related disorders like delirium, etc. So that is the line which it follows, whereas in ICD there is the chronology is not with regards to the age. It follows a different way of describing the disorders, which probably Dr. Trideep will be able to help you with, which is initially it starts with the organic causes and then it comes to the more psychology and psychiatry based disorders. So a lot of you might wonder that what is organicity. So when there is a problem in the brain structure because of which there are certain like there is an injury, or there is a stroke, or there is something with regards to seizure disorder, and because of which there are certain psychological conditions or psychiatric conditions arising, that would be termed as organic disorders. So, when we are talking about neurodevelopmental disorder, that is with regards to the brain development and childhood related disorder, the common disorders which we need to know are autism spectrum disorder. I know that a lot of people talk about intellectual developmental disorders, that is important. Autism spectrum disorder is something which has had certain changes in DSM-5 and DSM-5-TR. Attention deficit hyperactivity disorder, a lot of us know about it. We do not have complete knowledge about it. So a combined presentation, or predominantly inattentive presentation, or predominantly hyperactive presentation. Specific learning disorders, which would include your dyslexia, that is with impaired reading, that would be dyslexia. With impairment in written expression, that would be dysgraphia. And impairment in mathematics, that would be dyscalculia. And there are certain motor disorders which are described in neurodevelopmental disorder, which would include something called as Tourette syndrome, or tic syndrome, tic disorder. So these are the various disorders which have been classified in the neurodevelopmental disorder. Now, when we talk about the next section, which follows the neurodevelopmental disorder section, is the schizophrenia spectrum and other psychotic disorders, which also has included certain personality disorder which are similar to schizophrenia. So it does not really um, uh, sort of have that demarcation particularly. It also includes delusional disorder, brief psychotic disorder, schizophreniform disorder. When we are talking about schizophrenia, schizophrenia is the presence of, I would be trying to explain each and everything in very concise form, because like Dr. Tadeep mentioned, this is going to be a tedious job to explain everything. If you have questions, you can always ask. So schizophrenia is the presence of delusions, hallucinations, disorganized behavior, disorganized speech, with certain other characteristics like negative symptoms, alogia, apathy, etc. When it is present for a certain duration, it can be diagnosed as schizophrenia, and there can be various specifiers as to what kind of schizophrenia it is. So, subtypes of schizophrenia can be there. When it comes to brief psychotic disorder and schizophreniform disorder, it is only different in the duration of which it is present for. So, it has a shorter duration as compared to schizophrenia. When we are talking about delusional disorder mainly pertains to the presence of delusion. So it can be a delusion of grandiosity, it can be a delusion of infidelity, etc. Schizoaffective disorder is something where we have the presence of schizophrenia symptoms, that would be the delusion, hallucinations, disorganized behavior, etc., along with the presence of mood symptoms or the affective symptoms, which would be the depressive symptoms or the manic symptoms. Now, there can be times when certain psychotic disorders can be present because of any other mental health and any other medical condition. So it can happen, like I mentioned, that it is a possibility that it might happen in certain brain injuries. It can happen in certain individuals with seizure disorder. So these are the psychotic. There is a possibility that there can be a psychotic disorder which can develop in situations like that. Catatonia associated with another medical condition is another thing. Catatonia is a has been a type of psychotic disorder. It basically pertains to maintaining prolonged periods of a certain posture along with certain other symptoms. But catatonia over the period of time has been decreasingly seen. So it is not as evident as it used to be way back in a few years back. So that is catatonia. Unspecified catatonia, again, it pertains to the catatonia, but there is no particular reason as to why it is happening. That would be unspecified catatonia. Other specified schizophrenia spectrum and other psychotic disorder, unspecified schizophrenia spectrum and other psychotic disorder. So other schizophrenia spectrum disorders which are coming, and other psychotic disorder which does not fit in any of the above categories. So that is under the other specified and unspecified category here. Coming to bipolar and related disorders, like it has been mentioned, bipolar disorder is a mood disorder. It is something where a person experiences bouts or periods of, depressive mood, low energy, decreased interest in pleasurable activities. That is a depressive period and a manic period. So that's the name bipolar. So there are two poles of it. That is one pole of it, that is the depression. Mania is the other pole of it, where there is increased energy levels, increased decreased need for sleep. So now there is this particular sentence: decreased need for sleep is that the person will not require as much sleep. They might be able to function with just 2 hours of sleep. So usually when somebody is coming, they say that we've not been sleeping, we want to sleep. But somebody with mania would not have that you know requirement. They would say that we're sleeping 1 hour and that is comfortable for us, and they're able to function at a good level. And changes in mood, either increased happiness or irritability, is something which can be seen in bipolar disorder. Now, what is bipolar 1 disorder? What is bipolar 2 disorder? Bipolar 1 is an episode of depression along with episodes of mania, whereas bipolar 2 disorder is episodes of depression along with episodes of hypomania. Hypomania is another form, or a smaller or a milder form of mania, is what we can say. Here, the disruption is not as much. When we're talking about disorders, dysfunction is something which is important, but here the disruption is the main difference between mania and hypomania. A person in mania will have a lot of disruptive behavior with regards to themselves, with regards to people um, around, whereas in bipolar 2 it is not as much. So that is hypomania and depressive episodes. Cyclothymia is, like it says, cycling between, the two phases, but in milder form. So something which is not um, completely does not fit the category of depression, and something which does not completely fit the category of mania. So there is cycling between the two phases, that is cyclothymia, and for a certain duration of time, that is when cyclothymic disorder can be um, diagnosed. Substance and medication induced bipolar and related disorders. So when we are talking in terms of bipolar, a lot of times we see that there are certain medications which are used in general medicine, which are used in psychiatry, which can lead to a person experiencing bipolar disorder. And that can be certain medications with regards to general medicine. Like I said, they can also be certain of the medications which are used in psychiatry. So it is a possibility that certain substances, we know very commonly that substance induced mood disorder or substance induced psychotic disorder is something which is very commonly seen. It is related to increased use of marijuana, very commonly cannabis, and it is also related to alcohol usage at times. Bipolar disorder related due to another medical condition, that is another category. Certain times, because of another medical condition happening on the side, certain people can experience bipolar symptoms and be diagnosed with bipolar and related disorder due to another medical condition. Other specified bipolar and related disorder, unspecified bipolar and related disorder, unspecified mood disorder. So when it does not fit into the bipolarity aspect is when we would say that it is unspecified mood disorder, and there does not seem to be any symptom which is fitting in the other category. So these are the bipolar and related disorders. Coming to depressive disorder, one of the most common disorder which we come across in psychiatry and psychology, disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder. Premenstrual dysphoric disorder is something which is there in under the depressive disorder. Substance medication induced disorder, depressive disorder due to another medical condition. So most of this would be the same as the bipolar disorder or the schizophrenia, like the depressive disorder, due to another medical condition. There are certain medical conditions because of which one can develop depressive disorders, or other specified depressive disorder, unspecified depressive disorder, and unspecified mood disorder. Now, when we are talking about premenstrual dysphoric disorder, it is a, as the name suggests, it happens during the premenstrual period where one can experience depressive symptoms. And it specifically happens only during that period. It is not something which is persisting, which is pervasive. It is not something which is happening in that sense. It is, localized to the time when one is about to have their menstrual menstruation starting. It starts a few days before and it persists throughout the menstrual period. So it is with regards to the menstruation. Persistent depressive disorder is having milder forms of depression for a prolonged period of time. And when I say prolonged, it is 2 years of a period which has been mentioned as the uh, duration for which depressive symptoms need to be present at a milder form for it to be called as persistent depressive disorder. A lot of you would have heard the term dysthymia. This was something which was called as dysthymia as well. Major depressive disorder, we all know that depressive disorder is categorized by persistent and pervasive low mood, decreased energy levels, and decreased interest in previously pleasurable activities, along with other associated symptoms, which can be with regards to difficulty in concentrating, negative thoughts, sleeping difficulty, difficulties with their appetite, suicidal ideations, self harm thoughts, so on and so forth. A duration of 2 weeks is something which is important to note for depression. Somebody having these symptoms for, say, 3 days and then feeling better would not be categorized under major depressive disorder. So, persistent depressive disorder is milder forms for 2 years, and major depressive disorder is these symptoms in varying permutation and combination present for a span of 2 weeks or more. So that is what is covered under depressive disorder. Anxiety disorders are separation anxiety disorders, very frequently seen in children, selective mutism, specific phobias, social anxiety disorder, panic disorder, agoraphobia, substance medication induced anxiety disorder, anxiety due to another medical condition, like mentioned before, other specified anxiety disorder, unspecified anxiety disorder. When we are talking about anxiety, we need to understand that there are certain categories. So something like panic, something like social anxiety, something like specific phobia would be very situational. It would happen and then it would not persist. It would just be localized. So panic happens for a while. It is not something which keeps on going or is generalized. So it is something where there is intense peak of anxiety which lasts for a few minutes, and then there is a decline. So there is a bell-shaped curve of the anxiety which we see. When it comes to panic, it may or may not be provoked. So that is another categorization which we need to understand with regards to panic. Social and specific phobia and social anxiety disorder is more with regards to a situation or a specific object. It will not occur in other places. If you're at home, you will not experience social anxiety disorder. Social anxiety disorder is basically when one experiences anxiety when they feel that they would be negatively evaluated. Say it is a presentation, say it is an examination, say it is a important meeting, something like that. Specific phobia, again, something which is very situational and which is very specific and localized, but it would happen only in the presence of a certain situation or a specific object. Say somebody has claustrophobia, which is phobia of smaller spaces. That would be something where one would experience anxiety only in small spaces. So if the person is out of that small space, they would not have anxiety. So this is the spectrum of the anxiety disorder, which is categorized. Generalized anxiety disorder is something which is present all the time, which is present throughout the period. The person feels on the edge. The person is excessively worried about each and every small thing. There is no localization which happens. So that is the transition which one can see in with regards to the anxiety disorder. Agoraphobia, somebody has asked what is agoraphobia. Agoraphobia is phobia of exiting, or where they feel that exit might be a problem. Agoraphobia usually happens in places like when there is a large amount of public present in a place like a concert, where the exit seems far away, the exit seems difficult. That is where one can experience agoraphobia. So that is what is agoraphobia.
Yeah. Dr. Sambhavi, can we take a break?
We can, sure, sir. We
Yeah,
can
yeah,
take.
5 minutes. They are asking for a break. Then we'll go for the questions regarding the topics that have been covered.
So somebody's asked a question, can PMDD be reversed? It is definitely something which can be helped with. It is basically dependent on the biological aspect. So you do require the intervention of, a psychiatrist, and possibly the assistance of your gynecologist as well when we are talking about PMDD. But to just answer in same plain English, yes, it can be helped with.
Someone has asked, what does anxiety due to other medical condition mean? Different medical conditions, say diabetes, or say hyperthyroidism, or say different medication uses can give rise to anxiety symptoms. For example, steroid uses sometimes can give rise to anxiety symptoms. Hyperthyroidism can give rise to anxiety symptoms. So these are different medical conditions where we find not anxiety disorder but anxiety symptoms. Someone has also asked the difference between bipolar and cyclothymia. Again, when you talk about bipolar, it's either a manic episode or a depressive episode. So for mania to be diagnosed, the timeline has to be for about, say, 3 days. Sometimes, in cyclothymia, the manic symptoms are there, but it is not for the adequate duration of time, or say not all the criteria which are required to be diagnosed as bipolar are not there. Fine. So sub-threshold level of hypomanic or manic symptoms along with depressive symptoms, they give rise to cyclothymia, kind of a cycle. Goes from depressive symptoms to manic symptoms and manic symptoms to depressive symptoms. So that is what cyclothymia is. So sometimes it is also known as mixed episode. So DSM probably they haven't mentioned as mixed episode, but they have used is cyclothymia. MDD and PD, persistent depressive disorder difference. So as Dr. Shambhavi has said, see, when you talk about MDD, major depressive disorder, what DSM has used is major depressive episode. So an episode, to call it an episode, it has to be for a week, for a time period of 2 weeks. Fine. Now, what they have said is DSM, if say two episodes are, there is a interval of say about 2 months, then these are two different episodes. Fine. So again, persistent depressive disorder, if the depressive disorder is at least for two years. Fine. So prolonged period of time. Initially in ICD, what they have done is they had used the term dysthymia. So it was low-level depressive disorder for a period of 2 years. What DSM-5 tier has done is that they have used the term persistent depressive disorder. So here, if is a major depressive disorder that have persisted for 2 years or more, then according to DSM-5 tier, it is known as persistent depressive disorder. But if we see ICD-10, then that would not be mentioned as dysthymia because the depressive symptoms in dysthymia is less. So that's the difference. In PDD, persistent depressive disorder, the major criteria is the time period, 2 years. So it might consist both MDD for 2 years and dysthymia for 2 or more years. So there's a difference. In ADHD, as Dr. Samvi has mentioned, there are 3 types: combined type, inattentive type, and hyperactivity type. So hyperactivity type, there we also find impulsive symptoms. So it is either combined, that consists of inattention plus hyperactivity and impulsivity, or either or only inattentive type, or hyperactivity and impulsive type. So hyperactivity and impulsivity symptoms, they generally present together. So now what is impulsivity? Say, for example, someone asks you a question, and before the question ends, you just blurt out the answer. So that's an impulsive reaction. So if those symptoms are very persistent, so then that is found in the combined type, or the hyperactivity impulsivity dominant type. So what's the difference between mania and ADHD? Someone has asked. So ADHD is a neurodevelopmental. So the symptoms should be seen according to ICD-11. Some of the symptoms should be many of the symptoms should be there even before the age of 12 years. DSM-5 tier, what they have said is that um, some symptoms should be there at least before the age of 12 years. So that is a strong indication towards starting of the symptoms in a very early age, in a developmental phase. So that's what ADHD is. There's a huge developmental factor involved, a biological factor involved. Whereas in mania, although mood disorders may develop in adolescence, but uh, it did not have a, it doesn't have a neurodevelopmental, since a childhood. It doesn't have a, you know, the symptoms doesn't start from the very early childhood. So that's the difference between mania and ADHD according to how it starts. Moreover, if we go through the symptoms, the symptoms are quite different.
So somebody's also asked, what if someone has common symptoms which are present in two or more disorder? How to know the appropriate disorder? It is a possibility, like I mentioned before, that there might be certain overlapping symptoms which can
Yeah.
be present. A detailed history is something which would help you understand that, okay, more of this disorder is what is fitting more than the other. But a lot of times we are not able to come to a definitive diagnosis when we are initially seeing a person, and that's where the differential diagnosis comes into the picture. Differential diagnosis is basically having a set of diagnoses which are probable in this particular case. So say that somebody is having um, symptoms of anxiety but not fitting the criteria, but we feel that if we probably get more history, it might fit the criteria. Somebody having symptoms of depression. Also, when we have multiple disorders, we also need to give importance to something which is more dysfunctional to the person. And also there is a chronology which we can there is a possibility that there might be dual diagnosis as well. And when there is dual diagnosis, we need to understand which is the major diagnosis which is there, and which is the other diagnosis. So initially having differential diagnosis is something which can help when there is a confusion with regards to the diagnosis.
That's why they have probably given the specifier. Lots of specifiers are there. Symptom specifiers are there. For example, a depressive disorder patient might have anxiety symptoms. Then we can mention it as a specifier. So depressive disorder with anxiety symptoms. So that's why the specifiers are used. So for to label it as disorder, the set criteria has to be met. But the person might have other symptoms too, of which might be a part of an other disorder. So I think till anxiety disorders, most of the questions are answered.
A lot of
What is
people have
yeah
sorry, Dr. Sudeep.
yeah? What is selective mutism? Someone has asked. So it is generally found in children. So they would do is that they would be very vocal, or they would be having conversations normally at home, but in unknown places, or say with strangers at school, they would remain very silent, or would not start a conversation, or would not answer to questions. So that's what selective mutism is. Yeah, Dr. Samvi, we were wanted to
No,
say
I was
something.
just going to address the same thing, selective mutism. So somebody's also asked that how can one differentiate between PMS and PMDD? PMS is a set of symptoms which can be present during your menstrual cycle, not really causing dysfunction. Also, PMDD refers to depressive symptoms being present during your menstrual cycle and causing dysfunction in your life. So that is the broad uh, difference between PMS and PMDD. Right. So I think
Yeah.
we've covered most of the questions. We can move forward now. So coming to obsessive compulsive and related disorders, obsessive compulsive disorder, a lot of us would have heard. Obsession is basically the presence of intrusive, unwanted, repetitive thought, image, or an urge. It is not just a thought; it can be an image or an urge. Uh, it can be accompanied with a compulsion, which is basically the act to help reduce the anxiety which is developed by the obsession. So there can be a cycle. There is a repetitive, intrusive, unwanted thought which comes into our brain, mind. It leads to a lot of anxiety. We attend to the compulsion, the anxiety reduces for a bit, and then the same process sort of repeats. So that is obsessive compulsive disorder. Body dysmorphic disorder is when somebody has this concern or this anxiety around a certain part or the appearance of how they look, which causes anxiety, which causes dysfunction again. That is body dysmorphic disorder. Hoarding disorder again has been classified under obsessive compulsive and related disorder. It is when there is excessive and unnecessary accumulation of an object, something like a vessel, something like a polythene bag or a paper bag, where we feel that okay, this might be useful later on. Then the anxiety of having to use it later on and not having access to it makes us keep accumulating the particular object. Trichotillomania is basically, like it says, hair pulling disorder. There is a strong urge associated with anxiety to pull out hair. A person can have bald patches because of trichotillomania, which one can present a lot of times. A person who's struggling with trichotillomania might also ingest the hair, which can cause certain medical related concerns. Excoriations, that is skin picking disorder, is again classified under obsessive compulsive and related disorder. Substance medication induced obsessive compulsive and related disorder, obsessive compulsive related disorder due to another medical condition, other specified obsessive compulsive and related disorder, unspecified obsessive compulsive and related disorder. Now again, you will see that the last three or the four sections keep on following or are present in all the disorders. So there is a possibility that due to certain medical conditions, the emergence of OCD symptoms or OCD can happen. There is a possibility that certain medications or certain substances at times can lead to obsessive compulsive or related disorder. So that is what we covered here. Trauma and stress related disorder. Dr. Tadeep, would you want to take it forward?
Yeah. So trauma and so before coming to trauma and stress-related disorder, I would like to answer one of the questions. So one of the questions that was asked was why OCD is removed from the anxiety category or why it's not put there. So why the idea of putting OCD spectrum disorders is that it creates a common platform and it creates a common plan of management for these disorders. Although anxiety or distress might be there in the OCD spectrum disorders, but the core symptoms is the you know repetitive intrusiveness of the thoughts, the images, or the urges. Only when those are targeted, the accompanying anxiety or the distress would go away. So, for the sake of the plan of management, they have been put in a different category. So trauma and stress related disorder, when we talk about it, there are different disorders starting from reactive attachment disorder. So what is reactive attachment disorder? So it's basically seen in children, and uh, it is associated with the primary caregiver the child generally associate with. It might be a mother, it might be the father, or a mother-like figure or father-like figure. So generally, what does a child do when the mother is present, or the child generally respond to the positive emotions, right? They would either laugh, or they would either smile, they would feel happy. In reactive attachment disorder, this is not there. The response to the positive emotions, or the emotional connect with the primary caregiver is, or the attachment figure is not there. Or sometimes they might be reactive to a selective attachment figure, but would not be reactive to both the parents. So that's what reactive attachment disorder is. So if that is there, we have to look at how the attachment has been during the childhood growing up, or was there a prolonged absence of the primary caregiver from the child, or there has been any trauma. So all these things has to be looked into. uh, Disinhibited social engagement disorder, again, here the person would be unnecessarily, or say without any reason, be very friendly with strangers. Disinhibited social engagement disorder. Post traumatic stress disorder. So it's a very important diagnosis, in the sense that we get a lot of persons with post traumatic stress disorder. So, if we look at DSM-5 and ICD-11, there's an interesting finding. What they say is that using the ICD-11 criteria, um, what they have found is the incidence of post-traumatic stress disorder is lesser than using the criteria for DSM-5 tier. And why is it so? Because in DSM-5, the symptoms has been very, broadly described, very well described. Whereas in ICD-11, the symptoms, as they have said, are not that well described. Number two, uh, if we look at the kind of stressors that can give rise to post-traumatic stress disorder, again in ICD-11 and DSM-5 tier, there has been some differences. What they have done in ICD-11, what they have done is they have used the term overwhelming stressor for post-traumatic stress disorder, whereas in DSM-5 tier, what they have said is the stressor needs to be overwhelming, but at the same time, the kind of exposure to the stressor is more important. Say the person should have direct exposure to the stressor, or the person may have witnessed such an event, or say person might have heard about about something bad happening to loved ones, or say a person might have been repeatedly exposed to the aversive content of the stressor. For example, a medical intern, say during the COVID period, is repeatedly exposed to people who have lost due to COVID. That becomes a stressor for post traumatic disorder. That might become a stressor for post traumatic disorder in that person. Fine. Directly witnessing, say in front of my eyes something bad had happened, or directly involved, say I might have met with an accident, I survived, but I would have the post-traumatic disorder. um, um, I haven't been involved, I haven't seen, but I have heard about that something bad happening to my loved ones. That again can give rise to post-traumatic stress disorder. Again, in children, below the age of 6 years, what they have said is key. If something they have seen in social media of highly stressful, something they have seen in social media and electronic media, that cannot be regarded as post a stressor for PTSD. So that's the differences they have mentioned there. Moreover, the symptoms are very well described in DSM-5. also this is described in ICD-11. Acute stress disorder, post-traumatic disorder, it has to be there for at least, Dr. Sanghavi, you correct me, what the, I think the time period would be more than 1 month in
Yeah.
PTSD.
Yes. So
Whereas,
it has.
yeah,
That's correct.
and in acute stress disorder, it has to be less than 1 month. Again, adjustment disorder, if we consider adjustment disorder is, say we are going to a new environment, you are adjusting to new places or new, phases of our life, that might become a stressor for us. What they have said is adjustment disorder, the stressor has to be, the symptoms of adjustment disorder has to arise within 3 months of the onset of the stressor. Say a person, has joined a new place, new workplace, and the symptoms have arisen after say 4 months of the event. That is not considered as an adjustment disorder because it is beyond the 3 months of the stressor. But if it is within 3 months of the stressor, that can be considered as an adjustment disorder. Moreover, if the symptoms are there for less than 6 months, then it is acute adjustment disorder, simple adjustment disorder. If it is more than 6 months, then it's prolonged adjustment disorder. Again, prolonged grief disorder, it's a response. Grief is a normal response to loss, because during loss of a loved one, uh, we all go through phases of denial to acceptance. Now, what DSM has said is, if these symptoms are so prolonged, so beyond 12 months, then it is prolonged grief disorder and needs intervention. Why they have um, put it in under a classification? Because beyond 12 months, it needs intervention. Similarly, in other categories, other specified trauma and stress-related disorder, unspecified trauma and stress-related disorder are, put in here, so that we can put all other, miscellaneous trauma and stress-related disorders in this category.
So
So this
prolonged grief disorder, I would just like to add here that prolonged grief disorder is a new disorder which has been introduced in DSM-5 TR. It wasn't a disorder which was present in DSM-5. So we would be
yeah.
discussing that again later.
So dissociative disorders, Dr. Samavi, if you can,
So dissociative,
yeah.
definitely. So dissociative disorders are when one dissociates, as the name suggests. It is, not being able to identify the reality, being detached from the reality, experiencing loss of connection between what is real and unreal, between your thoughts. It can be emotions, it can be memories. So there is dissociative identity disorder, there is dissociative amnesia, there is a depersonalization and derealization. Depersonalization is with regards to a person. The person feels as if they are detached from themselves, and when one feels that there is a feeling of detachment, a feeling of detachment from the reality, from the environment, then it is called as derealization disorder. Then there are other specified dissociative disorder and unspecified dissociative disorders which can be present. So this is with regards to uh, dissociative disorder. Coming to somatic symptoms and related disorder, there is something called as somatic symptom disorder, where there is a concern with a certain symptom occurring to the person. This symptom may not be present for the whole duration. There is a lot of distress because of this particular symptom being present. Say it can be a single symptom of somebody experiencing pain in a certain part of the body. Whereas illness anxiety disorder is more of a fear of either acquiring an illness or having the illness, and due to which there is distress which one experiences. Functional neurological symptom disorder is also called as conversion disorder, but the current terminology is functional neurological symptom disorder. A lot of times, certain psychological stressors can present in the form of certain motor and sensory components, such as if somebody is seen seizure is one of the common uh, disorders which we see in functional neurological symptom disorder. um, they would not have the organic or the technical uh, problems with regards to one who is actually having a seizure, but it is more of a seizure happening to them because of the psychological stress. So that is what is functional neurological. So we call it pseudo seizure when it comes to this. It can happen with regards to numbness in the certain part of the body. It can be weakness with a certain part of the body. So it basically mimics a physical health disorder, either a stroke, a seizure, something like that. Psychological factors affecting other medical conditions, factitious disorder where there is presence of certain symptoms, again because due to a gain which they can have because of the presence of symptoms. Other specified somatic symptom and related disorder, unspecified somatic symptom and related disorder is when the symptoms are present but they do not fit into the category of either somatic symptom disorder, illness anxiety, functional neurological symptom disorder, etc. So that is when we would classify them under unspecified somatic symptom and related disorder. Coming to feeding and eating disorders, pica is a disorder which is seen mostly in children. It is with regards to eating any uh, 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 inedible sort of
Inedible.
material, that is mainly mud, is something which we commonly come across. So that is pica. It happens due to certain disturbances, certain problems with their developmental period. Rumination disorder, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, binge eating disorder. These are the common eating disorders where we see that avoidant restrictive food intake disorder is that a person can have distress or difficulty with regards to a certain type of food or a certain texture of food or a certain smell with regards to food. So these are the things which can be problematic for a person with avoidant restrictive food intake disorder, because of which their eating patterns change, because of which they are skeptical about not eating, and it starts to hamper their functioning, it starts to hamper their health. Anorexia nervosa is another eating disorder which is classified or characterized actually with the symptoms of, there is a pursuit to thinness and there is a fear of fatness which one can experience. Now anorexia, what happens is that um, there would be restriction of intake of food. So the person restricts themselves from eating too much, avoids being at places where they would have to eat in order to maintain that body weight or maintain that BMI. Bulimia nervosa is somewhere, again, there is a pursuit to thinness and there is a fear of fatness, which one experiences here. But the difference is that here the person has bouts of eating or bouts of eating excessively to the extent that they feel uncomfortable, following which there is a compensatory behavior in bulimia nervosa where they would experience wanting to get rid of the calories, wanting to throw up, and it can be something which can be induced, it can be something which can be um, uh, reduced with excessive use of medications, taking laxatives to get rid of the calories, excessively exercising. So there is a compensatory behavior which happens in bulimia nervosa. Binge eating disorder, again an eating disorder where there is again a binge is excessive eating in a short period of time, to the extent that the person feels uncomfortable, the person can have pain in their stomach because of excessive eating, followed by a sense of guilt, a sense of shame, self-loathing, etc., where there is no compensatory behavior like bulimia nervosa here. Other specified feeding or eating disorders and unspecified feeding or eating disorders would be seeing some of these symptoms not fitting into the criteria of, say, avoidant restrictive food intake disorder, anorexia nervosa, bulimia nervosa, binge eating disorder. So that would be the feeding and eating disorders. Elimination
Yeah.
disorder, Dr. Tradeep.
Yeah. No, nothing. Just carry on. After this elimination disorders, we would like to take some questions then.
So would you want me to carry on with elimination
Yeah.
disorders?
Yeah. Let us finish this off. Elimination
Okay.
disorder.
So elimination disorders, usually when these are related to, again, childhood specifically, not seen so much in the adults, but it is developmentally inappropriate. Enuresis is when there is passage of urine, and encopresis is when there is passage of stool. So usually we see that a child, when they have their developmental years, over a period of time they gain control over passing urine and passing stools. But here there is a problem with that because of the psychological development in their formative years, because of which there is persistent passage of urine at night, not being able to sort of control it, not being able to get up to pass urine, and same with passage of stools as well. Yes, now we can take some questions.
Yeah. So one of the questions that was asked was, what is the difference between bulimia and binge eating disorder? So,
Bulimia
uh,
is basically where a compensatory behavior is present. It is, both are eating disorders. Bulimia is when the person eats either excessively, or they can also eat at the usual level, but following this episode of eating, they would have this urge, or the need to want to get rid of the calories, because they are fearful that they might, gain weight, and there would be body dysmorphia, which would be present, causing this distress for them to happen. Whereas in binge eating disorder, the compensatory behavior is not present. It is more of the psychological self-loathing, the guilt, the shame, which causes the problems. Dr. Pradeep, would you like to add something to it?
no, I think that's perfect. I think there was another question which was asked is, what is the difference between dissociative identity disorder and derealization and depersonalization? I think depersonalization is where you feel as if you are out of your body, and it occurs. It can occur during severe anxiety. Sometimes derealization is where you feel as if the world that you are in is not real. This is basically a dissociative mechanism, so that because the person is not able to handle the anxiety, and his or the person's memory dissociates the identity, the presence of the person, it dissociates from the reality. So it is a defense kind of a mechanism where the person dissociates from the anxiety for that time period. um, Dissociative identity disorder is where,
Dr. Sudeep, your tea, sir.
so I'm being
Young
served.
people, if you want a 2 minute break, you can take a 2 minute break while I've got some tea for Dr. Shambhavi German and Dr. Sudeep Chaudhary. Do I get you something else? Okay, I've been thrown out, so I'm going out.
So we're being served tea. That's very kind. Dissociative identity disorder is where a person might have different identities, or say someone a person might feel that they are being possessed by some other personalities, and uh, the person doesn't remember what is being done during the presence of the other personality. So it is again a kind of a dissociation. For example, if a person has a history of trauma and all, then dissociative identity disorder, dissociative symptoms are being seen.
A lot of people are asking for a break, Dr.
Yeah,
Tradeep. Would
yeah,
you?
I think we should take a break. This is a very much deserved break.
Sure.
2 minutes.
They all took a break and left me here. They first sent me to get tea, nibu pani for themselves, and by the way, they had aloo chaat. And now they've left me to speak. Oh God, I tell you. Okay, I'll give you the answers. Let me see. Don't. Nobody laughs at me. Okay? Dr. Shambhavi Jamin is laughing at me. You are also, I saw that. Acha, theek hai, chaliye. I'll take some answers. I will give them a break a bit. Yes, I shall continue. No, I won't stay with you. I will get them back. But let me take some answers. Okay. Difference between anorexia nervosa and bulimia. Okay. Try and understand it like this. In eating disorders, look at these three different aspects. In binge eating, you have episodes where you have uncontrolled eating happening, binge. In fact, on this particular word, binge, I want you to understand this. You must be reading on social media at times that you say that this is a binge worthy show. So there is nothing binge worthy. In fact, um, whether it is a substance which is binged or whether it is food which is binged or anything which is binged, you are looking at not having the control, and you are, for example, in eating, I ate more than what I should have or wanted to, and I also, in a shorter gap, am repeating the whole cycle, right? So that becomes binge. Now, when you move forward in bulimia, you may have binge, but in bulimia, and you may have the compensatory behavior, but the key aspect in bulimia is that the weight difference in anorexia and bulimia would be different. Anorexia patients typically have very low weight, bulimia may not, and anorexic patients is more about the preoccupation with weight and doing compensatory behaviors without the binge. And in bulimia, you have compensatory behavior which is with the binge. And in compensatory behavior, it could be purging, vomiting, over exercising, all of that comes. But the one common factor is preoccupation with weight. The difference between anorexia, the weight is significantly below the required weight. Yes, good evening. So, when you say that why does a certain disorders come, let's say, in a category, you mentioned OCD as a spectrum. Look at the common aspect of obsessive compulsive spectrum. You are looking at an intrusive thought process, an intrusive thought. It could be an image. Then it's also giving you certain, let's say, arousal, in this case, anxiety, forcing you more often than not to have a compulsive behavior by and large. I mean, just understand this conceptually. Let's not look at it very rigidly. Now, in very similar, you will see happening in some other illnesses where you have an impulse, you have an intense arousal, you have a mechanism which you are doing. While you are doing it, it may be in some way distantly related to the cause of your anxiety, but it becomes kind of a repetitive pattern, an obsessive pattern of sorts. The reason why factitious comes in the somatic is soma. Soma means body. Factitious, the factitious element of the soma, which is the body, that's what makes it factitious. But the difference between somatization and conversion and even dissociation for that matter, in factitious, it is intentional. So that the Munchausen's and Munchausen's by proxy, one of the things about factitious would be pseudologia fantastica, which means I have those fantastic, colorful stories because I want the kind of attention to my illness and wanting the attention from the care provider. The care provider would be different than the caregiver. Care provider is the medical fraternity. Somatic symptoms. Soma means body. The symptom in my body, which is not caused by the body, but gives me the same feeling as though the symptom is there, causing me impairment of functionality. Panic attack, anxiety attack. Anxiety attack is more term that is now used a lot more, but essentially it will always be a panic attack. Assignment, I think they should have pinned it. If they haven't, then they'll probably share it again. See, feeling anxious meaning we can all feel emotions, right? So I may feel anxious before an exam. I may feel anxious before a result. I may feel anxious before an important thing happening. I may be anxious if I'm getting late, so on and so forth, right? We may be anxious because we are sitting here and you have somebody seeing you. So that's the feeling of anxiety. Now, being anxious and having a panic attack are two different things. Being anxious and having an anxiety disorder are two different things. Disorder will always have an impairment of functionality. No, so in bulimia, people may have low weight also, but the drastic aspect of anorexia is very, very stark actually. There are just way too many questions coming, so I'm not being able to see other specified versus unspecified in each chapter. So see, when they say not otherwise specified or other specified, look at two aspects. There are some core specifiers, which means I may be having a certain illness, let's say depression, and I may be having a subcategory or a subcore specifier to understand some nuance of that illness. Not otherwise specified or unspecified essentially is that I'm able to see that there is a problem, but it's not fitting in the exact definition of a disorder, but it still is having significant impairment and having the category of symptoms and signs of that particular illness. And that's why that category is there. I'll probably come here every other day whenever I can, but you have better experts for this. I am not the best expert in most things, actually, to be honest. The question is good. There is and I don't think the question here needs to be only to a psychologist. A psychologist, it could be a psychiatrist also, any mental health practitioner. We will need to look at illnesses incompleteness or symptoms incompleteness. There is a biological element, there is a psychological element, there is a social element. And that's why it is important to be aware. If I am a psychologist and let's say I have a patient who is having depression and I do not refer the patient for medical intervention, and let's say the patient needed it and I delay it and I continue having my sessions, then in a way that's impairing the treatment process, right? But at the same time, let's say I'm a psychiatrist, I give medications, but there are significant psychosocial factors which need to be addressed, and I'm only addressing the biological factors and not referring them for psychological intervention. Then again, it's not going to give a complete treatment. Combined treatment is largely applicable for most conditions. More importantly, we should be prepared for that, which basically means we should be open for that. The problem is that a lot of times we are not open. The biological intervention, they do biological, the psychological, they do psychological. And I think we need to interact a lot better and make sure that work together. I think that's something very important. So you are not deciding that medical intervention is required. You would know. For example, let's say you are working with a patient with depression. Now you know the guideline is that if there is mild depression, then you can give only therapy. Moderate to severe, you will look at medical intervention. If you are feeling this person is having mild to moderate, moderate to severe, you refer to the psychiatrist, continue doing your therapy sessions, and tell the patient you may or may not require medication, not my expertise. Why don't you talk to the psychiatrist? They'll tell you. And vice versa also. So if I'm the psychiatrist and I put someone on medication, I will say the same thing. For therapy, why don't you go and start taking therapy? There is robust evidence that combined pharmacopsychotherapy actually are more efficacious than any one of them for most situations. Uh, To be honest, I appreciate your question, the DSM, ICD, and cultural context. But the whole idea of having symptoms and impairment of functionality takes away the cultural context to a large extent. At the same time, DSM does have a significant material on cultural component, and I encourage all of you to read it. I spoke about it yesterday also. We need to be very culture sensitive. Yes, I have inspired me to choose this field. With 15 days, I'll answer some of these questions, maybe if we get time. Today, we'll stick to what we are doing. Do you think diagnosing clients can make them label themselves? I have typically not been comfortable with diagnosis and labels being put together. Because do we say that for diabetes? Do we say that for cancer? Do we say that for COVID? Do we say that for gastrointestinal or neurological problems? At the end of the day, we are talking about medical illnesses. DSM, for example, Dr. Jayman told you is only psychiatry, but ICD has all aspects, right? So if ICD has multiple chapters, one being psychiatry, why should a psychiatry diagnosis be any different than a gastro diagnosis? It's an illness, a diagnosis. It becomes a label when the social narrative around the illness and around this person uses that diagnosis or misuses that diagnosis to create stereotypical labels and do discrimination. Otherwise, it won't be the case. Similarly, for the patient also, it's also about how I and others are approaching that, right? It's not merely about, hey, you have this illness, hey, you have that illness. You are having a diagnosis because this diagnosis gives you prognosis, comorbidity, tells you what to look for, tells you when to utilize other forms of treatment, so on and so forth. Okay, I think I should now leave and I'll uh, anyone can be diagnosing. I mean, even a physician can diagnose, right? Try and understand it like this. Diagnosis follows a certain structured pattern. We need to follow that structured pattern. In fact, my opinion has been, especially given the deficit of experts, I would like more and more family physicians to be also involved at some level in giving treatments to people, both in terms of diagnosis and treatment, because the sheer deficit of experts that is there needs to be addressed as well. I mean, I am a firm believer that family physicians and general physicians, at least in some illnesses in initial episodes, to be able to look at that. Yes. No, fair point. that when we talked about that symptom based criteria and the criticism around it. But I think you will also need to always look at the CD and the other criterias. A lot of times when we discuss ICD or DSM specifically here, we just look at the symptom listing. It's very important that you also look at the other aspects of listing, which is impairment of functionality. If you remove impairment of functionality, then it becomes an issue, right? For example, let's say somebody comes to you and says, I'm feeling sad. Now, if you would not use the 2 week criteria, if you would not use the other symptom signs listing, and you would just end up saying this person has depression and put this person on treatment, medical or psychosocial, that's not the point here. Just by saying there is sadness, then obviously it's a problem. But now you put the context of other symptoms, also put the context of impairment of functionality. In absence of impairment of functionality, mere listing of symptoms is not a diagnosis. No. Diagnosis, like I said, from physician to psychologist, clinical psychologist. I mean, psychology as a field also has so many. I mean, if we look at our program, we have people who do health psychology, we have a sports psychology program, we have art-based therapists who work in clinical conditions, we have psycho-oncologists, we have a very strong psycho-oncology work that we do. We work in grief bereavement, consultation liaison. Then we do the clinical psychologists also do the psychometric evaluations for diagnostic clarifications. So yeah, essentially you are looking at a work that happens as a team, and I fundamentally believe that combined treatment is the way forward, and that we need to involve uh, we need to act completely, right? So for example, if somebody, let's say, has a medical illness, but you don't focus on the lifestyle correction, you don't focus on the psychosocial stressors, why only the context of psychiatry illness? I mean, let's look at a medical illness for that matter. Let's say somebody is having a cardiac problem. Now if this individual is having a cardiac problem, then what happens is, would you not, or and if let's say I have a cardiac problem, let's say I'm having a psychosocial stressors, then would only my cardiologist be treating my illness, or would a psychologist also be required to help me with my stressors, right? That's combined treatment. And it's not only about mental illnesses. We need to understand the context of this. How do you ensure your client is not lying about their symptoms? Someone's come to us for help, even if there is a context where there is, let's say, it's taking time, there is resistance, they take time for rapport. To see it in the line of, is this individual being honest or lying? I don't think that's not judgmental and empathetic. I don't look at it like that. You will always have people who will say things. I mean, you you can't allow what people say to change who you are and what you say, right? You say you do what you do with the ethics and intensity that you can, right? I have now, what you've been hearing our two colleagues now for an hour and a half. You pick something in or out of the context, and then you have your own interpretation. I mean, everybody is very free to do what they want to do, but which is okay. People will say what they say, and that's absolutely fine. Advocacy program, not today. Today you focus on the clinical work, not but advocacy is something I do believe in. But then I also believe advocacy is for everyone. We all need to create awareness about mental health and reduce the stigma. I think there is way too much stigma, and people just don't get help because the sheer perception that people want to the sheer perception that people feel that they'll be discriminated against, and that prevents help. I mean, even today 3 in 4 people don't seek help, which is very, very unfortunate, and that bothers me. Question on ethics, you can report anyone you would wish to. but that's up to you. And reporting of any behavioral pattern follows their own protocols, right? There are different ways where you can, based on what that is. I mean, that's just because an individual is practicing in one particular field, that they're not out of the gamut of the ethics. I don't think ethics can be compromised. And people will people have the right to respond, people have the right to criticize, people have the right to point out to your faults if there are any, and we will all have them. I mean, that's okay. You don't get offended when someone says something, you don't get bothered when someone says something. People have a right. They can choose dignified or undignified ways of saying what they want to, but that's okay. That's absolutely fine. I am what we do. Locus of control is what is in me. External locus is not in our control. It's okay. Don't get bothered by too many things. Now I'm going to let the young psychiatrist be back and take some of your questions. I'm going to leave you because you need to be with more knowledgeable people than me. So let me add Dr. 3D back and Dr. Shambhavi, who's taken a nice long break. Now you should bombard her with as many questions as you can. And I'll try and drop in tomorrow again. You can sit here, I don't sit here.
I was sitting to observe and learn. We thank Dr.
Yeah.
Parekh for explaining and helping us with giving you more knowledge and experience that he has. Yes. Dr. Sri, would you like to take
Yeah,
the sleep?
yeah. So after a long break and some refreshing words from Dr. Parikh himself, we're back to studying the DSM. So sleep-wake disorders, it has been divided into insomnia, hypersomnolence disorders, narcolepsy, breathing-related disorders. So when you talk about insomnia, not being able to sleep for a certain period of time, probably it's Dr. Hanabi, you would correct me if I'm wrong. It's for about a certain period of time when we call as chronic insomnia for about 3 weeks. Then insomnia can again be, the difficulty might be in the onset of sleep, or it might be in the maintenance of sleep, or say, one might have fragmented sleep. So again, when you come to hypersomnolence disorder, the symptoms may the sleep may be for a longer period of time, say and beyond a period of say 6 to 9 hours. Narcolepsy is a condition where you tend to
I want to learn also.
yeah there's a it is also called sleep paralysis because the person tend to sleep for longer period even during the day. So there is basically um, mm, a phase of paralysis where the person cannot get up. Breathing related sleep disorders, obstructive sleep apnea, central sleep apnea, sleep related hyperventilation, and circadian rhythm sleep disorders. So obstructive sleep apnea is where it occurs during periods of sleep. A person who might be having might have increased body weight. There is obstruction in their respiratory tract, and there is obstructive sleep apnea. Central sleep apnea again, something which is related to hypothalamus, sleep related hyperventilation, and circadian rhythm sleep wake disorder. uh, when the circadian rhythm is disturbed, a person might sleep for the adequate number of hours, but again the person might you know sleep early and wake up early. This is known as circadian rhythm, where it is advanced. Sometimes it is delayed, where a person might sleep late and wake up late. Again, parasomnia. These parasomnias are behavioral disturbances which occur during sleep. It might occur during non-rapid eye movement sleep. Non-rapid eye movement sleep is a part of a sleep cycle, uh, which is divided into non-rapid eye movement sleep and rapid eye movement sleep. Um, Nightmare disorder. Nightmare disorder is different from sleep terrors in the sense that nightmare disorders, the person doesn't wake up, but the person tends to remember the dreams. Whereas in sleep terror, the person wakes up, but doesn't remember the dreams. Rapid eye movement sleep disorders. Uh, Restless leg syndrome. Restless leg syndrome is where the person feels as if something is creeping on his or her legs, and it occurs during periods of relaxation or when a person is going to sleep. Um, it might occur in different conditions like you know say anemia, or a ferritin deficiency. It might occur during kidney diseases. It might occur due to certain medications. So here generally benzodiazepine group of medications do really work well. Substance and medication induced sleep disorder, again different substances, very common. Alcohol, one who is habituated of taking alcohol might have sleep issues, along with other anxiety issues. So besides this, other insomnia disorders are classified as other specific, unspecified, and the other categories, the other miscellaneous disorders are classified as other specified and unspecified um, insomnia and hypersomnolence disorder. Mm, Again, sexual dysfunction. Here, uh, the, again, the sexual cycle can be divided into desire, then erection and ejaculation. So sometimes the desire might be there, the erection might be there, but the ejaculation may be delayed. The ejaculation may be delayed because of various reasons. Medical issues are more prominent. Uh, then comes female orgasmic disorder, female sexual interest or arousal disorder. So again, in female orgasmic disorder, it's difficult to reach the orgasm. Female sexual interest and arousal disorder, or male hyperactive sexual desire disorder. Basically, these are disorders where the desire to have that physical intimacy is not there. Mainly found in different depressive disorders. Then the pelvic pain penetration disorder. It might be there in persons who might have some trauma, during previous such encounters, and might be very apprehensive of such an physical intimacy. Premature ejaculation is where the person ejaculates, the male ejaculates before a certain period of time, and many times it causes a lot of anxiety in um, young males, and certain medications are useful to help with this condition. Substance and medication induced sexual dysfunction. Certain substances like alcohol and all can bring sexual dysfunction. There may be difficulty in erection and ejaculation. And other sexual dysfunction disorders are placed as other specified and unspecified sexual dysfunction. Gender dysphoria. So gender dysphoria, in the earlier ICD-10, it was defined as gender identity disorder, where a person, if the person would identify themselves as in a gender, not in a gender different from what the person was assigned at birth, that was considered as a disorder in ICD-10. But in DSM-5, that there has been a major difference in the sense that, having a different gender than that assigned at birth is not a disorder. And only if the person has some kind of conflict within, themselves, uh, regarding their assigned gender at birth, fine, only then that can be regarded and have certain symptoms of dysphoria, fine, for a certain period of time, only then uh, then it requires intervention. So again, gender dysphoria, it is a very long process. So it involves a lot of medical uh, people from different fraternities. It involves surgery, it involves gynecologists, it involves psychiatrists. So a better coordination between them, and working on the awareness part will bring a lot of healthy developments regarding diagnosing gender dysphoria. So disruptive impulse control and conduct disorder. Dr. Sounding, can you carry on from here?
Sure. So, disruptive impulse control and conduct disorder, here again, oppositional defiant disorder, like the name suggests, it is something which is seen in children. It is something where there is defiance or opposition to an authority figure, which can be seen in individuals with oppositional defiant disorder. So, the main characteristic which we need to keep in mind is the opposition or defiance behavior. They can be argumentative, they can be mood disturbances, again impairing the function of the person. It would lead to oppositional defiant disorder lasting for a certain duration, again is an important criteria. Intermittent explosive disorder is something similar, where there are certain significant bouts of disruptive behavior which can happen. It can happen. A person can say that it can usually happen in somebody who's getting angry suddenly. It is a possibility, yes, but it's not a disorder unless there is impairment with regards to the symptoms present. Conduct disorder is with regards to not following or not, being able to abide by the rules and the regulations, the societal norms. So that is where the conduct disorder comes in. They would be breaking of the rules. There would be disruptive or destructive behavior as well. There can be harm to animals or destruction to property, which can occur in this, again described in children. Antisocial personality disorder, when these symptoms have been present as a part of personality, if this is something which has imbibed in their personality as a personality characteristic. Most of the time, when one is diagnosed with oppositional defiant disorder or conduct disorder as a child, uh, a lot of times antisocial personality disorder is something which they present with as adults, and personality disorders are only diagnosed when one turns 18 and beyond. Pyromania is around fire and destruction because of lighting matchsticks or with the intention of destruction. Kleptomania is this in uncontrollable urge or this uncontrollable tendency to pick up things. It's not with the intention of stealing it, but it is just with the intention of taking something which is not yours. Other disruptive impulse control and conduct disorder, unspecified disruptive impulse control and conduct disorder, again something which is if it does not fit the criteria of, say, oppositional defiant disorder, intermittent explosive conduct, then it would fit in unspecified or not otherwise specified. Um, what's the difference between oppositional defiant disorder and conduct disorder is one of the questions which just came into my sight. So, oppositional defiant disorder is when it comes to an authority figure. right? An authority giving you an instruction or telling you that this is something which needs to be done, and there is opposition or defiance with regards to that. When it comes to conduct, it is with regards to the societal norms, it is with regards to the rules and regulations of the environment and the society. So that is the difference between, but most of the times we see that oppositional defiant disorder would be present in the presence of conduct disorder. They can coexist. And like I said, that antisocial personality disorder is something which sort of is when one becomes 18 and they can be diagnosed with a personality disorder. Most of the time, when they have history of oppositional defiant disorder or conduct disorder, antisocial personality disorder can be present. A sociopath would be someone with conduct disorder. Sociopath is not a term which we use in psychiatry as a diagnosis, but yes, that behavior can be there. Uh, yes. So if conduct and oppositional are mainly pertaining to childhood, and personality disorder is mainly pertaining to adulthood, like I said, that personality disorders will be diagnosed only after the age of 18. Okay, moving on, substance related and addictive disorders. Now, again, substance, it is classified as substance use disorder and substance induced disorders. So, there are certain substances which can induce certain other disorders. We had seen that in bipolar, in psychosis, and even in depression and mania. So, substance use disorder mainly pertains to the usage of substance with where one would have impairment in control, craving, withdrawal, tolerance, and difficulty with their functioning and in social context. So when these five things are present, that is when one would say that for a certain duration of time. That is when one would say that there is substance use disorder. Substance induced disorder would be that somebody has been taking, say, a substance, and they have symptoms developing which are more of bipolar disorder like symptoms. So that would be substance induced disorder.
I think you can do it together here so that laptop doesn't have a charge. Why are you not having your teas?
I'm having my teas.
Wait, wait. Sit. Come, bring it here. Yeah, cool.
So the various substances which one can see these disorders with is very commonly alcohol, caffeine, cannabis, hallucinogens, inhalant, opioid, sedative, hypnotics, anxiolytic related disorders. A lot of people have this notion that sedatives are addictive. If one starts to take any sedative, they will have addiction with it. That is not always true. If one is taking medications prescribed by a mental health professional or a physician, is under supervision, the chances of having addiction drastically reduce. But yes, they have that potential. A lot of other medications also have that potential, but under supervision, under the um under the guidance of a medical doctor, those chances reduce. Stimulant related disorder, tobacco related disorder, the most common things which can induce another disorder are cannabis, alcohol, certain opioids, even hallucinogens. These are the substances which are commonly seen to uh, induce other disorders, other mental health disorders. When it comes to addictive disorders or addiction, there are certain other categories which are being introduced. One of them is gambling disorder, which is um classified under the non-substance related addictive disorder. Another category which has been introduced in DSM-5-TR is internet gaming disorder. It has been introduced in the further studies. It is still not introduced as a diagnosis, but it is something which is in the works to probably be added soon.
Yeah. So I had to shift here because of some technical issues that have been happening here. So when
The technical issue was that they did not have the charger, right? So the phone's battery got over.
So when we I missed in between. So when you talk about substances, I think the one thing that we need to notice here is in ICD-10 they have categorized as either dependence or intoxication or withdrawal. Now, what DSM has come with is a substance use disorder. They have mentioned as a single, terminology, and what they have given the explanation is that you know uh, when we are into a substance, it might be anything, right? It might be a medication, it might be anything. So when we are off that medication or when we are off that thing, then there will be some obvious withdrawal symptoms. There will be obviously, when I'm into that medication or substance, after some time the same dose would not have the same effect, and I might need a more higher dose. So what they have said that it is a normal thing. So that should not be categorized as a either dependence or tolerance. So what they have given is they have used it as substance use disorder, and they have given specifiers as either intoxication or withdrawal, or tolerance. When you come to behavioral disorders, as Dr. Samir was mentioning, gambling has been mentioned as a disorder here. I would like to mention some of the characteristics that are present in gambling disorder. Is when a person is into gambling disorder, there is a huge tendency to gamble from time to time, and obviously the person would not win every time, and when there are losses, there will be chasing of the losses. Fine, say I'm into gamble, suppose, and I put certain amount of money, and if I lose it, then there will be a huge tendency to again put another amount of money, that is changing the losses. And when that happens, that's where the impairment starts kicking in, because I will be investing a lot of money without a lot of thought process, and I might get into certain unacceptable ways of getting that money. So we should take a very detailed history of whether there is any changing of losses, whether there is any unacceptable ways of getting back the money. And as a person would feel very restless, would feel very anxious, and when the person is not doing the not into gambling disorder, so there will be kind of a dysphoria. So it is very important to discuss all these features and take the management approach. If we go, yeah, neurocognitive disorders. Somebody, do you want to take on?
So neurocognitive disorders comes under the category of certain changes in the brain because of the certain changes in the probably certain chemicals present in the brain. That is, delirium is something which can happen in with regards to say alcohol. It can regards to in the presence of infections. Delirium is a state of uh, disturbed consciousness or disorientation which is present. Uh, the symptoms which one can see in delirium would be sleep wake cycle reversal. There would be disorientation of the person. There could be certain hallucinatory experiences which one can experience during delirium. Delirium can happen due to certain substances, like I mentioned. It can happen due to certain other medical conditions also. Major neurocognitive disorder and mild neurocognitive disorder basically pertains to the changes in the brain structure over a period of time.
Yeah, cognition is where when you talk about cognition, there are different aspects. It might be the attention, the ability to focus, the ability to perform different complicated tasks. For example, my executive functions, right? How do I plan? How do I visualize? How to do things, or say working memory. When I talk about working memory, it is kind of multitasking inside my brain. Fine. 3D imaging, and all these are very complicated executive functions. So these are affected during neurocognitive disorders, major and mild. So how do I differentiate? There's a very what they say is, if my functionality is impaired, as Dr. Parikh was mentioning, then it is major cognitive disorder. Here, the activities of daily living, for example, how do I brush my teeth, how do I take care of myself, my daily activities. If I'm being able to do that, then it is. And even if the process has started, the cognitive deterioration has started, but I can do my activities, then it's mild cognitive disorder. If it is hampered, then if the activities of daily living are hampered, then it's major neurocognitive disorder. Very interestingly, they have majorly classified into two categories. They haven't mentioned classified into Alzheimer's, or say according to the cause, according to the organic cause, the DSM people. Whereas in ICD, different organic causes are mentioned. Again, when it comes to delirium is basically a clouding of consciousness, whether a person would fluctuate between being conscious, being confused kind of thing. And delirium occurs during various causes, as Dr. Sambhi has mentioned. It might be a medical cause, it might be substance abuse cause, it might be due to medicines. Sometimes major neurocognitive disorders can exist with delirium. And neurocognitive disorders, if it exists, and if a person, because of certain medical conditions, goes into delirium, that delirium can persist for a longer period of time. Again, personality disorders, if we see, again, DSM-5 has maintained the categorical classification of personality disorders according to ICD-10. But if you see ICD-11, they have mentioned personality disorder as a simple category. Fine. And what they have done is, for different disorders, as mentioned in DSM-5, they have as mentioned DSM-5, ICD-11 has mentioned as specifiers. For example, personality disorder with borderline traits, that specifier they have used. Whereas in DSM-5, they have mentioned as categories.
Paraphilic disorders are disorders where the sexual act has been the sexual act has been replaced by something else, like the
It's unacceptable kind of sexual behavior, which is unacceptable. And voyeuristic disorder is where kind of the person is gets pleasure by looking at something which is sexually arousable.
So something like a peeping tom would be considered as a voyeuristic disorder. So
exhibitionistic is someone who gets aroused by
unusual
acts of behavior, that kind of
sexual behavior. So when we talk about voyeuristic, exhibitionistic, all these are unusual sexual acts which actually replace the usual sexual act, and that is when these things are categorized under paraphilic disorders. Like Dr. Parikh had mentioned before, that the distress or the impairment is something which is very, very important for one to have, and that is when it would be categorized under a disorder. Medication-induced movement disorders. So certain medications used can have certain impact on the body, can have certain movement-related disorders. So this is how the medication-induced movement disorders have been classified. Neuroleptic malignant syndrome is another condition which can happen due to certain medications reacting a certain way in the body at certain dosages. Dystonia is again related to muscle spasm, which is significant, which causes distress. Again, can be is medication induced. Akathisia is a feeling of excessive restlessness, subjective restlessness, which is induced by certain medication. Tardive dyskinesia, medication-induced postural tremor, other medication-induced movement disorder, and antidepressant continuation syndrome, which is important for us to understand that sometimes when there is a certain amount of antidepressant which is being given to a person, the usual protocol to taper it off or to get off of it is to slowly taper the medication. However, in antidepressant discontinuation, if somebody suddenly stops the medication at a dose where the person should be actually tapering the medication, there can be certain symptoms which one can, flu-like symptoms which one can experience, and that is antidepressant discontinuation syndrome.
So between dyskinesia and dystonia, what I would say is dystonia is where the tone of the muscle is disturbed. Dyskinesia is basically the different movements occurs. Whereas akathisia is subjective restlessness, where we do not observe the restlessness, the person feels restless.
Right. So we are going to quickly go through the changes from DSM-5 to DSM-5-TR. Some of these changes are just with regards to the wordings. So the major changes which happened from DSM-5 to 5-TR was introduction of a new disorder, that is prolonged grief disorder, which was not included in the DSM-5. Inclusion of symptom codes for suicidal behavior and non-suicidal self-injury. So now there is a separate code for somebody having suicidal behavior or non-suicidal self-injury. There are certain refinements in the criteria which have been mentioned, like I said before, that they are basically with the technicalities and the wordings of how the criteria has been phrased. There has been comprehensive literature update which has happened with regards to the prevalence, prognostic factor, culture and gender related aspects, and ethno-racial factors. DSM-5 coding was removed. So there used to be a coding like in ICD, there is a certain coding. ICD-10 had F coding, ICD-11 has a different coding. DSM-5 also had a numerical coding which has been removed in DSM-5-TR, and now they refer to the ICD-10 coding. So it's gotten a little complicated over there. So prolonged grief disorder, the criteria for prolonged persistent complex bereavement disorder has been replaced by the criteria for prolonged grief. So previously there was persistent complex bereavement which used to be there. Now it has been called as prolonged grief. The name included in ICD-11 already has this. ICD-10 did not have it. ICD-11 has it. However, the criteria do not overlap completely. So ICD-11 has slightly different criteria of prolonged grief disorder versus DSM-5-TR criteria. It is estimated that following the non-violent loss of a loved one, 1 in 10 bereaved adults is at a risk of developing prolonged grief disorder. So like Dr. Sudeep had mentioned before, that there is a grief period which is considered usual and which would not be problematic for the person in terms of their functioning, but once it becomes impaired, once it becomes hampering to the functioning of the person, that's when it is diagnosed as prolonged grief disorder. So the criteria A says the death at least 12 months ago of a person who was close to the bereaved individual. For children and adolescents, it's 6 months ago. For an individual who's an adult, it's 12 months ago. One or both of the following symptoms which have been present on most days to a clinically significant degree. In addition, the symptom occurred nearly every day for at least the last month. So this is how the criteria is usually in DSM are. Intense yearning or longing for the deceased person. If this has occurred for a prominent amount of time in the last 12 months for an adult or last 6 months for a young person and occurred nearly every day for the last 1 month, then it could be diagnosed as prolonged grief disorder, or the presence of intense yearning and longing for a deceased person along with preoccupation with thoughts or memories of the deceased person. In children, adolescents, preoccupation may focus around the circumstances of the death. The criteria C says since the death, at least 3 of the following symptoms have been present most days to a clinically significant degree. The symptoms have occurred nearly every day for at least the last 1 month. Identity disruption, feeling as though a part of them has passed away or is dead. Marked sense of disbelief about the death. They are in denial. They are not able to accept the passing away of the person. Avoidance of reminders that the person is dead. They would want to avoid any sort of reminders with regards to the person who's no more. Intense emotional pain, which can come in the form of anger, bitterness, sorrow related to death. So the presence of these symptoms would be diagnosed as prolonged grief. Further, difficulty reintegrating into one's relationships and activities after the death. So difficulty going back to your own routine. Emotional numbness, absence or marked reduction of emotional experience as a result of death. Feeling that life is meaningless as a result of death. Intense loneliness as a result of death. If any of these symptoms are present, and the criteria says here that at least 3 of these symptoms from 1 to 5 should have been present for us to give a diagnosis of prolonged grief disorder. The disturbance causes significantly distressing periods or impairment in social, occupational, and other important areas of functioning. This is very, very important. The duration and severity of the bereavement reaction clearly exceed expected social, cultural, and religious norms. Like we said, that there is a normal period of grieving for everybody. There is a usual period of grieving. When this is unusual, when this is prolonged, is when this disorder comes into the picture. The symptoms are not better explained by any other mental disorder. So, if this person has a major depressive disorder which has been diagnosed, or a post traumatic stress disorder, then there is a conflict as to which should be given precedence. It is usually something which is more severe, more dysfunction causing illness, which would be given precedence in terms of the disorder if 2 or more disorders are present. Like I mentioned before, that code for suicidal and non-suicidal self-injury behavior has been added in DSM-5-TR, which was not previously there. So current suicidal behavior is a code. The suicidal behavior symptom code can be used for individuals who have engaged in potentially self-injurious behavior with at least some intent to die as a result of the act. So that is current suicidal behavior. Evidence of the intent to end their life can be explicit or inferred from the behavior or circumstances. Suicide attempt may or may not result in actual self injury, but the intent is something which is important here. So it can be classified into initial encounter if the suicidal behavior is part of the initial presentation. When the person is coming to you and they are reporting of this kind of behavior, it would be coded as initial encounter, current suicidal behavior. Subsequent encounter, if the person has been seeing you for a while and then this sort of um, 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 symptoms comes up, or then this kind of thought comes up, that is subsequent encounter, that is while the person has been seeing you. History of suicidal behavior, that is before the individual started seeing you. So in any time in their life before the individual started seeing you, that is history of suicidal behavior. So that is when we use these and this is exactly the same thing which I've mentioned before. Now, there is also a different criteria for non-suicidal self-injury. The non-suicidal self-injury is when somebody does not have the intent to uh, die, the intent to harm themselves with the intent of ending their life. If that is not present, then it is non-suicidal self-injury. Symptom code can be used for individuals who have engaged in intentional self-inflicted damage on their body, but the intention of uh, ending their life by suicide is not there. So absence of suicidal intent is there. Again, it can be classified into current non-suicidal self-injury if they are coming as a part of their clinical presentation with this symptom, then it would be current non-suicidal self-injury. If there is a history in their lifetime, any time before they've come to you, if they've had these symptoms, then it would be history of non-suicidal self-injury. Certain refinements in the criteria. This is going to be very quick when you read DSM-5-TR. Some of the things you might not be able to even notice from 5 to 5-TR because they are so minute, but that is what has happened. So, like I mentioned, that certain wordings have been changed. So, if you see here, the DSM-5, it mentioned that a persistent deficit in social communication, social interaction across multiple contexts as manifested by the following. Now, this sentence has been changed in DSM-5-TR as manifested by the following was revised to as manifested by all of the following. So it's just the last sentence, last part of the sentence which has been changed, just to give us more clarity that all these symptoms should be present. That is the change from DSM-5 to 5-TR. The change in mood disorder is that unspecified mood disorder was removed and now it has been added back. It used to be there in DSM-4 TR, but it was removed in DSM-5. Now it's been added back. Changes in bipolar 1, again, it comes to the wordings that they have made it more specific, more clear. At least one manic episode is the word which has been, is the phrase which has been added. Whereas in DSM 5, it used to just mention the occurrence of a manic episode. So at least one, they have made it more specific. That is the only change which we have done in bipolar 1. Bipolar 2, again, it is at least one hypomanic. Here it mentions the occurrence of a hypomanic. So they have just made it very specific. There is no major change in terms of the diagnostic criteria. In DSM-5 TR, yes, they have added specifier for both manic as well as depressive psychotic episodes for bipolar, whereas in DSM-5 they only had that psychotic episode specifier for the manic episode. Changes in severity specifier changes from DSM-5 has mild in DSM-5 TR. It has mild, moderate, severe specifier even for manic episode, whereas in DSM-5 again it had only for depressive episode. So these are similar changes from 5 to 5 TR in terms of the severity specifier and the psychotic specifier. Changes in cyclothymia, again with regards to the wording, have tried to make it more specific. So they had simply changed the word. The hypomanic and the depressive periods have been present for at least half the time. So they have just, this particular point is the criteria A in cyclothymia criteria. So they have just replaced that phrase with criterion A symptoms instead of writing the whole sentence to make it less complicated and more easily understandable. Change in major depressive episode, again, that is something for more clarification. They've mentioned at least one major depressive episode in DSM-5 TR, whereas in DSM-5 it was the occurrence of a major episode. They did not clarify as the number. Here they have written that it should not be superimposed on schizophrenia, schizophreniform, and delusional disorder. That particular word is again for more clarity. If you see in the DSM-5, that particular phrase was not there, so the clarity was less in terms of understanding. The change in post-traumatic stress disorder in DSM-5 TR, the change which they have made in PTSD is the only thing which was mentioned as a note for the criteria for children younger than 6 years was the note said witnessing does not include events that are witnessed only in electronic media, television, movies, or pictures. So now that criteria has been removed. So that means that if it has been witnessed in social media, electronic media, television, it can be considered as PTSD for children. Again, the wording with regards to change in substance medication induced bipolar, they have also mentioned withdrawal from a medication. Like we said, that some medications can induce a bipolar disorder. The withdrawal of certain medication can also induce bipolar disorder. So that is what they wanted to clarify here, and that is why they've added this particular wording. So certain changes in the terms which they have used with regards to gender dysphoria, significant updates in the terminology is that the term gender, desired gender, is now experienced gender. The term cross-sex medical procedure is gender-affirming medical procedure. The term natal male or natal female is individual assigned male-female at birth, and use difference in sex development instead of disorders of sex development. So it's not disorders of sex development anymore, it is differences in sex development. So they've made it more accommodating in terms of. In terms of the other changes, there are a few disorders where the names have been changed. We had mentioned this in depression when we were talking about depressive disorder. The term dysthymia has been replaced by persistent depressive disorder. So dysthymia was the previous name which we used to use for persistent depressive disorder. Conversion disorder, what we had explained, is now known as functional neurological symptom disorder. Intellectual disability is now intellectual developmental disorder. It's not intellectual disability anymore. And certain other changes in the development and course. If you go through DSM-5, you will see a lot of text for you to read in terms of the development of the disorder, the course of the disorder, the prognosis, the prevalence, the culture related aspects. So there are certain changes which have been introduced there as well in disruptive mood dysregulation disorder. Narcolepsy classification has been modified in accordance with the International Classification of Sleep Disorder 3 and ICD-11. So there's slight change in the narcolepsy classification. And initially, something which was known as social phobia has now been replaced by the term social anxiety disorder. So these are the basic changes which have happened from DSM-5 to 5-TR. There are certain other changes which are not particularly relevant at this point of time for you to know, but they are some things which one can go through. So, summarizing what we've learned today, diagnosis is not the only thing we need to look at, but it is definitely helpful in terms of guiding the treatment. It provides a standardization in terms of somebody who's sitting in India versus somebody who's sitting in another continent, and in terms of communication with regards to the treatment between the mental health professionals, in terms of one understanding the uh, uh, prognosis as well. It is something which is helpful. If there is a question as to which diagnostic classification should be followed, I don't think there is any better classification than the other. We should have the knowledge of both, and either can be followed. So that is what I would want to conclude with. Dr.
Yeah,
Chiti.
I think that's true. Both ICD and DSM-5 TR gives us insight from different perspective, and more than making a diagnosis, it gives us a lot of information and it increases the knowledge. And by going through those takes, we can get an insight of how our diagnosis should be approached. I think with that we can conclude the session and come to questions.
We completely understand that this session would have gone a little longer than what we would have expected, but sort of covering both ICD and DSM, and we've not even covered it completely. We've just given you a gist of how it is quite difficult.
So another question that was asked, I just quickly remember, was how to make the diagnosis of ADHD. And no, diagnosis of ADHD can be done clinically. We also at a hospital we use extensive testing, segmented testing. The cross-cutting measures as in DSM are used. Along with that, corner setting skills can be used. Teachers corner setting skills, self corner rating skills, parents corner rating skills can be used. And we should remember that adult ADHD in general, both adult and childhood ADHD. Uh, Besides the inattention part, what DSM 5 and ICD 11 has given a concept that it is more than inattention. It is something more related to the cognitive aspect. It is something which is related to executive functioning. So in the treatment process, besides the medicines, decreasing the inattention, decreasing the hyperactivity, parent training programs are given, and on an individual level with the patient, different measures are taken so that the person's cognitive functioning can be improved, and then the secondary outcomes like different depressive symptoms and anxiety symptoms can be controlled, and the person's self-esteem can be increased, and ADHD in general can be managed.
So somebody has a question about the duration of a manic and depressive episode. The depressive episode, like it was mentioned, that it has to be present for a span of 2 weeks or more for it to be diagnosed as depression. Again, there can be severity of mild, moderate, and severe depending on how many symptoms are being met. With regards to mania, it is somewhere between 3 days to 1 week, depending on the kind of disruption or the dysfunction which is present. Obviously, the symptoms which are present as well. So that is the duration of depression as well as mania.
So what they have said is that simply presence of the symptoms is not important, but if the symptoms are persistent, then it becomes a disorder. Because when it becomes persistent, then our daily activities are hampered. No disorder is most which disorder of all DSM are most life threatening? I think nothing, or everything needs attention. I know everything needs attention, but if there is a suicidal behavior, that's why they have mentioned it at in a different category, suicidal behavior or non-suicidal behavior. So if there is a suicidal behavior, then it becomes an emergency, and you know if someone around us have this kind of behavior, immediate attention is required. That can be life threatening.
We would definitely take this into consideration about the session being split into more number of days so that it's not so long. We will definitely try and hopefully implement it.
Yeah, we can do that in the future. Taking the feedback, we can bring in single sessions for ICD and single sessions for DSM. It all depends on your interest, and we can get back again.
Do you want to take this?
Is pornography addiction included among online gaming? Gaming disorders again. Uh, my knowledge of the literature is limited, but whatever I have read is that pornography probably is not included in gaming disorders, neither and obviously not in gambling disorder, because in gambling disorder there is you know um, it's bit different, where you invest something which there's a constant effort to regain that investment.
So the only two behavioral disorders which have been currently added and are in the
Yeah.
works of getting added, gambling disorder is already present. Internet gaming disorder is something which is in the works to be added in the future uh, editions of DSM. The assignment has been added by Anuna. We thank her for being there and helping us out.
Yeah, Aruna, thank you for for being here and helping us out. So Aruna is a clinical psychologist. So we have starting these sessions, arranging these sessions. There has been a lot of people behind us, so we're thankful to them for smoothly running these sessions.
You should definitely have the knowledge of DSM and ICD. I'm not saying that you have to memorize everything over your course of reading and training to become a psychologist. You will definitely be able to grasp and retain a lot of the criteria. So it's not that you have to learn them in the initial years of you starting.
Invest. This is done. And
So again, paraphilic disorder is something where the sexual act, the usual sexual act, is replaced by an unusual sexual act. The arousal or the satisfaction is, achieved by unusual sexual acts, such as where there is fetishistic disorder, where there is unusual
sadistic,
uh,
narcissistic.
satisfaction or achievement of the sexual satisfaction through certain objects. There is sadistic and masochistic disorders which are there. So these are unusual sexual acts which replace the usual sexual act, uh, because of which one is able to achieve a sexual satisfaction.
Can you again explain delusional disorder versus schizophrenia? So, schizophrenia, what they have said is, DSM-5 and ICD-11, if we see. So, in ICD, they have said schizophrenia symptoms, to diagnose the schizophrenia symptoms has to be for at least 1 month. DSM has mentioned it that the time duration is for 6 months. Again, DSM has said key symptoms should be disorganized behavior, disorganized speech, and delusions or hallucinations along with negative symptoms. What ICD-11 has added is Snyder's criteria. For example, somatic passivity and mid phenomenon. These are symptoms which were very, present when concept is a very conceptually, present symptoms. So ICD-11 have included them. DSM haven't included them. Now, delusional disorder is a disorder where a person would have a fixed firm belief, which is, which is not, doesn't have any evidence, which is circumscribed. Say a person might have delusion of, say, infidelity, or say have erotomanic delusion, where a person might think that that person is in love with another person, although that is not true. Fine. Delusion is totally false, but it is firmly fixed, and the person believes it, even the evidence is against it. But beyond that, beyond the delusion, the person is completely fine, or the person is doing all the activities, the person doesn't have any other symptoms. Person, his or her, the person's cognitive functions are totally fine. Whether in schizophrenia, besides the delusions, which maybe or may not be present, there are other, categories. For example, the person might have negative symptoms. That is, the person's might the person's effect might be, restricted. The person might not be able to feel the emotions, or the person might be very apathetic. So positive symptoms, negative symptoms, cognitive symptoms, that is, the person's processing speed might be very low, or there is gradual deterioration in schizophrenia in every domain. Whether it's in delusional disorder, the person will have delusion only regarding the circumscribed subject, or circumscribed, event.
How can we differentiate between agoraphobia and claustrophobia? So, agoraphobia is phobia of open spaces from where exit or getting out might be difficult. Like I mentioned before, that a concert with a lot of people around and the exit gate being at the other end. Whereas claustrophobia is the fear of small spaces, so elevators, washrooms, which are small in aeroplane, where it is a small tiny aeroplane or a tiny car. That all those places one would experience claustrophobia. But yes, sometimes the presentation can be slightly overlapping, so you will need to ask more questions and find out. But it is, agoraphobia is basically open spaces, big spaces from where exit might be difficult, whereas claustrophobia is small closed spaces. Um Pornography addiction is not a recognized disorder by DSM. Right now, like I mentioned, that the two behavioral addictions are gambling disorder and internet gaming disorder. Internet gaming disorder is not actively part of DSM-5-TR yet. It is in a section in DSM-5-TR which talks about further studies and addition of further diagnosis in DSM-5. When the diagnosing criteria for a disorder differs in ICD or DSM, which do we go as per? You would be following one classification. It's not like you would classify certain disorders by ICD-10 and certain disorders by DSM. Or what you can do is you can see what is your line of thought, what is the training in which what classification is being given to you, I think that is the classification which you should uh, follow for diagnosing. So it cannot be that some of the clients or patients we see as per ICD and some we see as per DSM. You have to have a classification which you tend to stick to, but it's not uncommon for us to sort of refer to another classification just to have more clarity.
So how depersonalization or derealization can be treated? So basically, you have to find out what the cause is. If there's anxiety, then to treat the anxiety. If there's trauma, to treat the trauma. So yeah.
I'll take this.
So preschool, adolescent, and old age. Again, DSM has so beautifully described. Put the disorders age-wise. So again, in if we see the prevalence, the diagnosis, the prevalence of ADHD has been increasing, partly because there is more awareness. The diagnostic criteria has been more specific, more elaborative, and we are more. The medical community is also more aware of diagnosing them properly. So ADHD is one of the common, but it's very hard to say which is the most common. Uh, ADHD is also found in adult, which is where the inattention part is more common than the hyperactive part is not there. So it is adult ADD. Old age, again, neurodegenerative conditions are quite common, as I have found in my practice. Neurodegenerative conditions are those major neurodegenerative conditions or mild neurodegenerative conditions like Alzheimer's because of Alzheimer's, or say Lewy body dementia. Post vascular dementia is very common. That is a major neurocognitive disorder because due to stroke, say, or some vascular cause, very common. Old age, geriatric depressive disorders are very common. Again, sometimes geriatric depression might be a bit different from adult depression, where in geriatric depression the symptoms, the depressive symptoms might be more, the person might be more apathetic, the person might feel more self-pity for themselves. In childhood depressive disorders, the child may not be able to express the low mood. The child might show irritability, clinging behavior to the mother. So not no specific disorder is common, but these disorders that have been discussed are quite easily found in these respective age groups.
Yes, substance use can cause psychotic disorders. Mainly substances like marijuana, cannabis, uh, definitely can cause psychotic disorders.
Assignments. Discuss assignments.
ODD is with regards to the authority figure and defiance, that is, opposition or defiance to an authority figure and the instructions which are being given by the authority figure or things which are being said by an authority figure. Whereas conduct is with regards to the social
Physical.
norms, the rules and regulations. So that is the main difference between ODD and conduct. So there is no particular classification which is assigned to us specifically. It is your school of thought. It is your training which sort of makes you follow one classification more than the other. So there is no assigning of a particular classification. Yes, areas of prevalence of DSM is more in the US, whereas ICD is more in other places. That is just because of the practice which is followed, uh, but no assigning of a particular diagnostic criteria. There are many psychiatric disorders or psychological disorders which have a genetic predisposition. So, say depression, bipolar disorder, schizophrenia, ADHD. A lot of these disorders have genetic predisposition. So, uh, if you have a first degree relative who has a certain disorder, the chances of the offspring getting it would be higher. Whereas if it is second degree, there are still chances, but the chances of the offspring getting the disorder is slightly lesser.
Alzheimer's is a type of dementia, and there can be different types of dementia, for vascular dementia. So the most common is Alzheimer's. Among the neurodegenerative dementias, the most common is Alzheimer's dementia. And if we consider neurodegenerative dementia, then the next common is Lewy body dementia. And if we consider overall all kind of dementia, then Alzheimer's comes first, then comes vascular dementia. So others are Parkinson's dementia, frontotemporal dementia. So there are different types of dementia according to the etiology.
I think the investigative modalities for neurodevelopmental disorder is a very vast and very broad question. If we are categorizing it into, say, ADHD, say autism, I think that is something which we need to know which neurodevelopmental disorder are we talking about here.
And moreover, say a person with attention deficit disorder, attention deficit hyperactivity disorder comes, many times there are so many comorbidities. Say ADHD might have conduct disorder, so it is very important to do an extensive testing and not only focus on whether the person has ADHD or not.
So, fetishistic disorder is a paraphilic disorder, like we said. There is nothing called as unusual sexual disorder. It is an unusual sexual act which gives us the same satisfaction or the same sexual orgasm as a sexual act, a usual sexual act would. I think we've ordered or answered most of the questions. Delusional disorder, schizophrenia, we've already given the answer for. I think we've completed most of the questions. If there are any more questions, you can always write to us and we will try and get back to you with the answers.
So Anuna says there, our host. So would like
Hi.
to.
Hello, Dr. Trip. Hello, Dr. Shambhavi. Thank you so much for the wonderful session. So, I would like to thank all the participants and along with our speakers for today's session. It was very, very insightful. We have learned a lot about the diagnostic criteria. So, thank you once again, both of you. Uh, uh, Before we end the session, I would just like to address few things. I think a lot of you are asking few things about the investigation question. We are going to have a specific class on assessments, particularly. I think on the fourth or fifth day. So you can ask all your questions then. They will be able to address it. And I would request you to please stick to the topic so that the speakers can take your questions specifically. Otherwise, we do not get enough time to address all the questions, and it keeps on coming up so fast, so it becomes very difficult for us to keep a track on the comment box as well. Plus, a lot of you are asking about the assignments. Both the assignment links, yesterday's and today's, are put in the description box along with the attendance links, so you can avail it from there. The attendance links are going to be active for a day, and the assignment links are going to be active till the end of the internship. Okay, with that, I thank you, all of you. Thank you, Dr. Shambhavi. Thank you, Dr. Tridip. We'll see all the participants tomorrow again, same time at 3 p.m. Thank you so much.
Thank you,
Thank you.
everyone.
Thank you, everyone.